Let's begin by reviewing the 4 standard views of the cardiac echo exam. The first view, as shown in probe position A, is the parasternal views, both long and short axis planes, and this is going to be performed directly on the anterior chest wall. The second view is where probe position B is shown here, coming from the abdominal position or the subxiphoid view of the heart. The last view is going to be shown by probe position C, the apical view of the heart at the point of maximal impulse. This module will specifically focus on the parasternal views, specifically looking at the long axis plane. There's a great deal of information we can get from the parasternal long axis plane, so let's learn how to perform the examination. For this examination, it's optimal to use a small footprint phased array type probe that can easily sit between the ribs. We're going to place the probe just left of the sternum at about intercostal space 3 or 4, with the marker dot on the probe aimed down towards the patient's left elbow if the patient's left elbow is down by the side. That's with the caveat that the ultrasound screen indicator would be over towards the left of the screen. This will align the probe in the long axis of the heart. Occasionally, it can be somewhat difficult to get a good view of the heart from this plane, and moving the patient into the left lateral decubitus position can sometimes help imaging from the parasternal long axis plane of the heart. So now let's take a look at the images that we'll obtain by performing the parasternal long axis view of the heart. Here's a nice pictorial to the left, and what we see is that the most superficial structure will be the right ventricle. Notice that the right atrium is not seen from this plane. Directly posterior to the right ventricle will be the left ventricle, and to the right of the left ventricle will be seen the left atrium. We can also see the mitral valve in between the left atrium and the left ventricle, and a little bit of the aorta above the left atrium. Let's look at the ultrasound still image here to the right, and again we see the superficial right ventricle. Posterior, we see the left ventricle with its more muscular and hypertrophic walls. Notice the left atrium as seen to the right of the left ventricle and the mitral valve in between the two chambers. We categorize this as left ventricular inflow tract. Note the aortic valve sitting right above the left atrium, and we see a little bit of the aortic root there. This is what we categorize as aortic outflow tract. Let's now take a look at the parasternal long axis view of the heart in action. Remember again that the most superficial chamber will be the right ventricle, and the normal dimensions of the right ventricle are that it should be about half the size of the left ventricle. If the right ventricle is the same size of the left ventricle, that could be a sign of RV strain. We see the left ventricle posterior to the right ventricle. Note its hypertrophic walls. This patient actually had long-standing hypertension. Let's look at the percentage change from diastole through systole, and here we see that the walls come in well with each heartbeat, indicating good contractility. We see the left atrium to the right of the left ventricle, and notice the mitral valve flipping up and down in between the left atrium and the left ventricle. We see here good movement of the mitral valve, indicating a good amount of blood flowing between the left atrium and the left ventricle. Now just above the left atrium and to the right of the left ventricle, we see the aortic valve, and notice there, just to the right of the aortic valve, a little bit of the diamond-shaped aortic root. This will be our left ventricular outflow tract. Now another very important structure to identify on bedside sonography is the descending aorta, which is a cylinder cut in cross-section right below the mitral valve as seen in this image. This is a very important landmark because the posterior pericardial reflection, that white line seen posterior to the left ventricle, comes off anterior to the descending aorta. This allows us to tell if the fluid that we see there may be pericardial or pleural. There's a great deal of information that we can gain by looking at the parasternal long axis view, looking for left ventricular contractility, the presence of a pericardial effusion, and also the possibility of right ventricular strain. Here's a video clip showing excellent contractility of the left ventricle as taken from a medical student triathlete. Recall the chambers of the heart as taken from the parasternal long axis plane, the left atrium as seen in a posterior location, the mitral valve just to the left of the left atrium, and the left ventricle as seen with its hypertrophic walls. Notice the strong contractility of this left ventricle as the endocardial walls almost meet during systole. We see the aortic valve to the right of the left ventricle and the right ventricle in a superficial location above the left ventricle. Recall the descending aorta, the cylinder cut in cross-section just posterior to the left atrium. And note the posterior pericardial reflection coming off just anterior to the descending aorta and posterior to the left ventricle. And with a small indicator arrow, I'll trace out the posterior pericardial reflection. Note here the absence of any dark or anechoic fluid collections. Now let's contrast that last video clip with this one taken from a patient with an advanced cardiomyopathy. We recall the left ventricle and the right ventricle in a superficial location above the LV. Notice the very poor percentage change of the endocardial walls of the left ventricle during systole, indicating a very decreased ejection fraction. Here's a clip taken from a patient who presented with a transplanted heart and acute shortness of breath. We'll begin by identifying the descending aorta, as shown here to the bottom part of the picture. Note the posterior pericardial reflection, that white line coming off just anterior to the descending aorta. But what we see here is the presence of a dark fluid collection, a pericardial effusion that layers out posteriorly above the posterior pericardial reflection and comes anteriorly to surround the heart. With a small indicator arrow, I'll point to the anterior portion of the pericardial effusion and note the chaotic movement of the right ventricle as shown here. This is indicative of early tamponade or high pressures within the pericardial sac. Here's a video clip showing a potential mimic of a pericardial effusion. Let's begin by identifying that descending aorta as a cylinder cut in cross-section posterior to the left atrium, and we identify the posterior pericardium as shown here coming off just anterior to the descending aorta. Note the presence here of a large dark or anechoic fluid collection, but note that it layers out posteriorly there to the pericardium. Thus, this fluid is within the pleural cavity and not within the pericardial cavity. With a small indicator arrow, I'm again reinforcing the pericardial reflection and the presence of the fluid within the thoracic cavity, a pleural effusion. Next, we'll look at a video clip from a patient who presented with acute shortness of breath requiring intubation. First, we'll begin by identifying the descending aorta, then the posterior pericardial reflection. Note here the presence of fluid both within the pericardial sac, as shown here layering anterior to the pericardium, and posteriorly within the pleural cavity, layering out just below the pericardial reflection. Why, you might ask, does the patient have all this fluid? Well, let's look closely at the mitral valve, and on the posterior mitral valve leaflet we see a calcified vegetation. This patient, in fact, had an infected dialysis catheter with mitral valve endocarditis and had developed wide open mitral valve regurgitation, resulting in heart failure and all the fluid layering out within the pericardium and the thoracic cavity. In conclusion, the parasternal long axis view of the heart gives a great deal of information about our patient's condition and can be instrumental in emergency care. Now, the parasternal short axis view of the heart can be very helpful in emergency care, as it gives a great deal of information about the contractility of our patient's heart. So let's look now further into how to perform this examination. The probe will be placed just left of the sternum at about intercostal space 3 or 4, as shown in the pictorial here to the right. Now, in variance to the parasternal long axis view of the heart, where the probe marker was positioned down towards the patient's left elbow, we'll swivel the probe 90 degrees clockwise, so now the marker is down towards the patient's right hip. That's with the caveat that the ultrasound screen indicator is positioned towards the left of the screen. Now, moving the patient into left lateral decubitus position may help imaging from the parasternal short axis plane. Here's what the views from the parasternal short axis plane of the heart will look like. We see a pictorial here to the left showing the left ventricle cut in cross-section as a cylinder, and the right ventricle as a little sliver just to the left of the left ventricle. We see an ultrasound image corresponding to the right, and note the left ventricle again, that cylinder cut in cross-section, and the right ventricle above the left ventricle more anteriorly and to the left. In this way, we get a good sense of the overall cylinder of the left ventricle and can gauge its contractility. Here's a video clip showing excellent contractility of the left ventricle as taken from the parasternal short axis plane, and note the muscular contractions of the left ventricle as a cylinder squeezing in dramatically during systole. We also note the mitral valve flipping up and down within the left ventricle, and the right ventricle as seen up and above the left ventricle. Now let's contrast this video clip showing excellent contractility with another patient who had an advanced cardiomyopathy. Note again the left ventricle, and note here the poor percentage change from diastole through systole, indicating an advanced cardiomyopathy with low ejection fraction. We can also see the right ventricle anterior to the left ventricle. For learning purposes, we'll identify the walls of the LV, the septum in between the ventricles, the anterior wall to the top of the screen, posterior wall to the back, and the lateral wall as shown here towards the right portion of the screen. Now, while I show the walls of the left ventricle here, it's important to realize that the goal of emergency echo at the bedside is to determine overall left ventricular contractility rather than looking for segmental wall motion abnormalities. So in conclusion, the parasternal short axis view of the heart gives a great deal of information about the contractility of the left ventricle. This will allow you to identify patients who may have a cardiogenic cause for their presentation. Heart is an excellent way of imaging the patient's heart and getting a lot of information directly at the bedside. Now let's learn how to perform the subxiphoid view of the heart. As shown in the pictorial to the right, the probe is coming from an abdominal position, placed just inferior to the xiphoid tip of the sternum. It's important to lay the probe flat and push down and under the sternum, aiming towards the patient's left shoulder. Now the marker dot on the probe should be over towards the patient's right side, with a caveat that the ultrasound screen indicator dot is over towards the left of the screen. Now it's very important to put your hands on top of the probe and really push down and up to get the good imaging plane underneath the sternum to make the angle to get a good view of the heart from this plane. Let's now take a look at the image that you'll obtain from the subxiphoid view of the heart. Here's a pictorial to the left and an ultrasound image to the right. The first chamber that we'll encounter directly below the liver, which is our acoustic window in this case onto the heart, will be the right ventricle. Immediately posterior to the right ventricle, we'll be seeing the left ventricle. And as shown in this pictorial, notice that it has more muscular and hypertrophic walls. From the subxiphoid plane, we'll also be able to image the right atrium to the left of the right ventricle and the left atrium just to the left of the left ventricle. We can also appreciate the white line that is the pericardium circumferentially surrounding the heart. Now that we know where the chambers are, let's take a look at a video clip of a normal heart from the subxiphoid plane. As we remember, the liver is our acoustic window onto the heart from this plane, and so the liver will be seen anteriorly just to the top of the screen. Just below the liver, we appreciate here the right ventricle, and notice here, just to the left of the right ventricle, we can appreciate the right atrium. Notice the tricuspid valve flipping up and down in between the right atrium and the right ventricle. Now let's look posterior to the right ventricle and we appreciate the left ventricle. Notice again its more muscular and hypertrophic walls. Just to the left of the left ventricle, we appreciate in this case the left atrium, and we also get a glimpse here of the mitral valve flipping up and down in between the left atrium and the left ventricle. Now let's look at that white line both anteriorly above the right ventricle and posterior below the left ventricle that is the pericardium. Note here the absence of any significant pericardial effusions. In that last video clip, we noted good contractility of the left ventricle from diastole to systole. Let's contrast that clip to this one from a patient who presented with shortness of breath and advanced cardiomyopathy. We see the right ventricle just below the liver, anterior to the left ventricle. And what we see here is a poorly contracting and dilated left ventricle, consistent with a cardiomyopathy heart. However, note the absence of any significant dark or anechoic fluid collections consistent with a pericardial effusion. Here's a patient who presented with renal failure and acute shortness of breath. We're again looking from the subxiphoid plane, so we see a little strip of the liver anteriorly, the right ventricle just below the liver, and the left ventricle seen posteriorly to the right ventricle. Notice how hypertrophic the walls of the left ventricle are in this patient. We also appreciate a dark fluid collection both anteriorly just below the liver and above the right ventricle and posterior below the left ventricle, consistent with a circumferential or large pericardial effusion. If we see a large pericardial effusion on bedside echo, our next move is to look for signs of cardiac tamponade. Here's a patient who manifests all the signs of cardiac tamponade on bedside echo. Let's look specifically at the right side of the heart. Notice the very large pericardial effusion and note the chaotic movement of the right ventricle as it struggles to open during diastole. The compression of the right ventricle in this patient is consistent with advanced cardiac tamponade. The right side of the heart is preferentially compressed before the left ventricle due to its lower pressure circuit. In conclusion, I'm glad I could share with you the Soundbites module going over the subxiphoid view of the cardiac echo examination. This is a very important exam to put into your routine practice in looking at your patient's heart at the bedside, and will tell you if the patient has a pericardial effusion, as well as giving a sense of left ventricular contractility. Also, the subxiphoid view of the heart gives better views of the right side of the heart than the more superior parasternal views of the heart. So the apical view of the heart is an excellent view and gives a great deal of information about our patient's heart, as it shows all 4 chambers of the heart in relation to one another. Therefore, the apical view of the heart is preferred by cardiologists as it shows the synergy of all of the chambers of the heart to one another. Now let's take a look at a pictorial showing how to perform the apical view of the heart. Preferably, you're going to be using a small footprint phased array type probe that can easily get in between the ribs. Position the probe directly underneath the left nipple at about the point of maximal impulse of the heart, with the probe indicator over towards the patient's right side. Now that's with the caveat that the ultrasound screen indicator is positioned towards the left of the screen. Now, moving the patient into the left lateral decubitus position can improve imaging from the apical view of the heart, as it moves the heart closer to the probe and moves the lung out of the way. Thus, it's important to consider moving the patient into this position when performing the apical view of the heart. Now let's learn how to interpret the images that we'll obtain. We see here a pictorial to the left and an ultrasound image to the right. As we're imaging from the apical view of the heart, we're closest to the ventricles, and in this image we see the left ventricle to the right of the screen and the right ventricle adjacent. The atria from the apical view of the heart will be further away, thus posterior to the ventricles. And we see here the left atrium just below the left ventricle and the right atrium below the right ventricle. We also see the valves, the tricuspid valve to the left and the mitral valve to the right in between the left atrium and the left ventricle. We can also appreciate the white line surrounding the heart, which is the pericardium. Now let's take a look at a video clip showing the apical view of the heart in action. This is taken from a medical student triathlete, so let's take a look at that left ventricle. We see the left ventricle in its more superficial location to the right of the screen. Notice the percentage change from diastole to systole. Note the walls almost touch with each heartbeat, indicating a good contractility. We see the right ventricle to the side of the left ventricle and the 2 atria posterior to the ventricles. Notice the mitral valve in between the left atrium and the left ventricle and the tricuspid valve to the right side. Notice here the absence of any significant pericardial effusion. Let's contrast that last clip from this patient who has a dilated cardiomyopathy. And as we look at that left ventricle from the apical view of the heart, we see a very poor percentage change from diastole through systole. This is indicative of a very poor contractility of this heart. We see the right ventricle to the side of the left ventricle and the 2 atria posterior. Notice the sluggish movement of both the mitral valve and the tricuspid valve. We see a little bit of pericardial effusion, that little black rim around the heart, also going together with this patient's cardiomyopathy status. Here's an interesting video clip of a patient who presented with acute shortness of breath. And what we notice here is the right ventricle and the left ventricle closest to the screen, but we see here a very large pericardial effusion circumferentially surrounding the heart. And notice the heart swinging back and forth in all the pericardial effusion. This gives rise to the phenomenon known as electrical alternans, or different sizes QRSs on the EKG. Here's a patient who was in bad shape and presented with acute shortness of breath. We see a very large pericardial effusion, and let's look specifically at the right ventricle. Notice that it caves in from diastole due to the high pressure in the pericardial sac. Thus, this is indicative of advanced cardiac tamponade. This patient will need a stat pericardiocentesis procedure. So in conclusion, I'm glad I could share with you the Soundbites module going over the apical views of the heart. This is an often neglected view, but one that gives a great deal of information about your patient's heart and really should be routinely integrated into the cardiac echo examination. It's best to move the patient into the left lateral decubitus position to optimize imaging from the apical view of the heart to see all 4 chambers of the heart in relation to one another. So I